Patient-caregiver relationship. I'll give you a little bit of an overview of a research study that, this is a small research study. It actually stems from some of the work that I did as part of my PhD. And so one of the outcomes of it was just some conversations that may help optimize care and some of the conversations that what we should have before bringing in a caregiver into care situations. So I'll give you an overview, we'll talk a little bit about methods, and the results are framed around a new model of looking at the doctor-patient-caregiver relationship, and then we'll talk about the 5 conversations. We'll hold our questions and discussion until the very end if you don't mind. All right, so the doctor-patient relationship, we all know that there's lots of models available to conceptualize the way that this is supposed to work. And over the last 50 years or so, we've moved from a disease-centered to a patient-centered relationship, and there's a greater emphasis on collaborative care. The patient needs to be engaged in, the care decisions that are being made, and the symptom review is done with the patient and not for the patient. The doctor now is responsible for talking to the patient about their ideas and their feelings about illness and health, and their experiences as well. And this is moving towards a more holistic approach to addressing the issues that the patient is dealing with. The patient's agenda is acknowledged, and the doctor and the patient work together to enable the patient to manage their care, not only in the clinical setting, but also moving into the home setting. So the doctor tries to enable the patient to be able to take care of themselves when they get home. So I'll show you a small clip. And so what I want you, there's no volume with this on purpose, and so I want you to watch this small clip. This is the typical doctor-patient relationship, just the interaction that happens in a medical setting. And then we're going to look at another one with a caregiver that's going to be involved in it. So, to some of you who were here a bit earlier, I had mentioned that I am a caregiver as well. I've been taking care of my dad for many, many years, but more recently I've been going into the clinic room with him. I've been accompanying him to hospital visits, and I've noticed a lot of things are different when I'm in the clinic room with him versus when I'm with the doctor alone, or when he's with the doctor alone and he comes back and tells me about the interaction. And so you'll notice that the doctor-patient-caregiver relationship is one which is most common with very young children and also very common with older adults. Now, caregivers do provide a very, very important, they play a very important role, and they provide continuity of care from one setting to another. They also act as a liaison person between the doctor and the patient often. But the caregiver often has their own agenda and their own information needs, and they also have their own values and beliefs which may not always be in line with that of the patient or the doctor. And so in the literature, the caregiver is often sometimes conceptualized as a second patient. And that video that I just showed you, that second video, you may have noticed, you're going to see that second video shortly. And I want you to notice the interaction between the 3 people who are present there. And, one of the questions we want to ask is, does the presence of a caregiver signal dependence? So all of a sudden, the relationship changes between the doctor and the patient, and now my dad is bringing me, or a patient is bringing a caregiver. Does that signal dependence now? So we'll watch this video here. Okay, just as a quick overview about older adults and caregivers, we all know that the population is aging in Canada and North America and across the world. And there's a greater reliance on caregivers and informal care in the home setting. And with the growing numbers of older adults, there's also a growing number of adults being accompanied by their caregivers to medical visits. And one of the things that's very present in the literature is the fact that there's a strong cultural context to this. So certain ethnic and cultural minority groups have a very strong reliance on family members, and there's a sort of an understanding or an expectation that this is something that's normal, and that an expectation of care is that they will be accompanied to medical visits by their children and also to provide care at home. And oftentimes in multi-generational homes, this happens as a result of a need for collective decision-making because, well, a parent's illness or a family member's illness affects everybody. And oftentimes it's just a matter of dependence that the older adult needs the caregiver to transport them to the hospital and be with them, and so as a natural progression they'll enter the clinic room with them. So the shifting of care to the home setting means that caregivers often are involved in care. And now collaborative care is also moving to include partnerships with families, and that the research suggests that there is improved health outcomes when there is a partnership between family members and their patients. Now, family members and caregivers often act as substitute decision making. However, as substitute decision makers, however, there's no formula for understanding if that person is A, willing, and B, able to be a substitute decision maker. And sometimes they're just thrust into that position of having to make decisions, and there's no real planning for it. Is the patient capable of making medical treatment decisions? That's oftentimes not assessed, and it's just understood that if the caregiver is present with the patient, that there's going to be shared decision making. There's really no guidance or official position for healthcare professionals on how to deal with caregivers accompanying their patients. Now, I'll tell you that most of the time when I'm with my dad waiting in the clinic, the doctor assumes that I'm going to be coming in with him, and that everything that is going to be discussed in the clinic with him is open to be discussed with me. One of the things that we looked at was the relationship that's contextualized in the literature, and it says, well, we have the patient and the caregiver on the one side, and we have the healthcare professional on the other side. So the other thing that I wanted to point out was that although we're talking about the doctor and the patient and the caregiver in this presentation, a lot of things that we're talking about are applicable to other healthcare professionals. So the expansion of the dyad to the triad, with the caregiver being present, is applicable to other healthcare professionals as well. And the reason I'm bringing this relationship up is to point out the fact that it assumes that the patient and the caregiver have shared values and beliefs and goals, and that that the healthcare professional has their own agenda and the patient and the caregiver have a very similar agenda, and that's not always the case. So what we know is that the presence of a caregiver, as I've mentioned previously, changes the dynamics of the interactions. If you think about the two videos that I showed you, the doctor was now having to talk to the patient and the caregiver. The caregiver is talking to the patient. The caregiver is talking to the doctor. So the dynamics of the conversation and health communication changes. And although there's a lot of very good aspects of the caregiver being involved, continuity of care, being a liaison, there's a lot of unintended consequences of the caregiver that are often not explored, and that was the point of doing this little research here. Some of the questions that I'm going to address as part of the conversations that need to happen ahead of time are, well, what information can everyone share? Is everything, shareable, or are some things off limits? What if there's a bad news diagnosis? What does the patient want to share? What does the caregiver want to know? These are things that are not assessed. Will the caregiver act as the interpreter? Does the caregiver even want to be present, or do they just have to be because they accompany the person to the hospital or to the clinic? What if there's more than one caregiver and there's a conflict? How are we going to resolve this? So what are the problems? Well, the interests of the patient are not always aligned with the interests of the caregiver or the healthcare professional, and so there is the potential for there to be conflict there. The caregivers may be in a position of influence with regard to the management of their parents' healthcare, but also the older adult might be living with the child, and so there is a dependency as well. And so what we want to do is we want to acknowledge that there's positive and negative aspects of this relationship. So the research question is, what are some common issues that arise when the doctor-patient relationship expands to include the caregiver? The objectives were to understand the issues that need to be discussed and prioritized when healthcare professionals are simultaneously dealing with older adults and their caregivers. And the reason I framed it as 5 conversations is because I want to highlight that those conversations often don't happen before. It's just the doctor invites the caregiver in, or the caregiver just, somehow becomes part of the interaction. But we need to have these conversations beforehand about how we're going to address these issues. So we used a qualitative approach. We conducted in-depth interviews with 23 adults.
Slow down a little bit?
Sorry?
Would you slow down?
Sure, sorry. So we used a qualitative approach. We conducted in-depth interviews with 23 people. And I think what was unique about this was that we conducted interviews over the course of a year. So we followed the disease trajectory We followed different changes and different experiences that the caregivers were having. So in total, we conducted 50 interviews with the caregivers. And then we just coded the data and organized everything around the major themes. So just as a quick overview of the results, the presence of caregivers impacts the healthcare interactions. Caregivers interact with patients in different ways. Well, obviously, many of the caregivers are family members, so they are not only a care provider, but they're a family member, and so they're managing dual roles. Caregiver interactions also change over time because that's based on dynamics of relationships with the people that they're taking care of. And so as family dynamics change, so do caregiver interactions. Okay, so we want to revisit this idea here that the patient and the caregiver are on one side and the healthcare professional is on the other side. And one of the things that we did as part of this research is say, well, the relationship actually doesn't look like this. The relationship actually looks like this. And what we want to acknowledge here is that this relationship is changing. It's dynamic. It's not a static one as the one as this suggests. And that over time, the caregiver and the patient might find greater alignment, or the healthcare provider and the patient might find greater alignment. And so these relationships are constantly moving and are in flux. Because we'll get to the good stuff now, which is the 5 conversations. In these 5 conversations, I want you to know that there's some cases. I've used some quotes to highlight how we got to the conversations. And then the other main point is that the cases that we've developed here are to highlight some ethical issues that could come up and then some conversations that are related to that. So in case 1, an elderly family member does not want to know if they're going to die. And they suggest that the only thing that needs to be talked about with them is general health concerns, and if there's a bad news diagnosis, that only the doctor and the caregiver are to talk about it. Okay? And so, well, the caregiver says to us, how do you handle death before it happens? Like, how do I not tell my father? We have differences in engaging my father in a conversation about what he wants. That is a sort of a lot of conflict. And so the conversation that we suggest that should happen beforehand is, well, let's discuss how we'll handle a bad news diagnosis or a crisis situation. We have to discuss issues of capacity, competency, and legality of non-disclosure. And the doctor friend that I worked on this study with, this little small portion of the study with, said, you know, we have something called therapeutic privilege. And therapeutic privilege suggests that I can withhold information because there's this idea that if the information I'm going to provide is going to cause harm to the caregiver or to the patient, that I can withhold that information, and that's part of therapeutic privilege, and that becomes a problem sometimes because the interpretation of therapeutic privilege is contentious. The second case, an elderly family member and their caregiver want the doctor to make all of the medical decisions when there's a conflict in terms of values, beliefs, or what direction to take with regard to care. And so, just as an example, the quote is, and I know a lot of people who have experienced exactly the same thing. The sons and daughters, the person who care about him, actually is from one who suffered too. And I don't want this type of pressure, you know, because only he's sick. Well, the conversation that we suggested that should happen is, well, when we are all together, that's the doctor, the patient, and the caregiver, decisions should be shared amongst all, but we must always prioritize what the patient wants. If not, we need to decide who will make the ultimate decision with regard to care for the patient. And most oftentimes, the ultimate decision, the medical decision, needs to be made by the healthcare provider. An elderly family member has not been using their medication as prescribed, and this is very, very common. This happens with my dad as well. This information is shared by the caregiver with the doctor prior to the clinic visit. The family member, when asked with the caregiver in the clinic room, tells the doctor that they have been compliant with their medication. And so the associated quote with that is, you know what the most challenging thing is? I know that sometimes my parents go see the doctor. They don't necessarily tell them everything. Not necessarily tell me everything either, because they don't want us to worry. They don't want their children to worry. And so there's a strange negotiation that's happening here, because the caregiver knows that the patient is not telling everything to the doctor, but all these people are trying to work together to improve care for the patient. But how can that happen if one person knows something, then the other person not telling you things? Again, the prioritization has to be on the patient. So the conversation that needs to happen as a result of this is we need to establish information sharing boundaries. What information can we share with everyone? Because oftentimes what happens is that when the patient says, I have been using my medications, and the caregiver says, no, you haven't, that conflict creates a situation where it's hard to move forward from. Well, what do you do then? The fourth case, and this is again from our data, an elderly family member is not sure if they want to be resuscitated if something happens to them. They're not sure. This is the whole point, okay? They haven't made a decision. Do I want to be? Do I not want to be? I don't know. One of the two caregivers, who identifies as religious, says that not resuscitating the family member would be a sin. The other caregiver states that they do not agree that the elderly family member should be resuscitated. So there's a family dynamics conflict here. And so the conversation we need to have is, who's going to be that one person that's going to be healthcare proxy? Because the last thing that people want is for there to be a DNR situation and no one being able to decide, well, what's going to happen here? From this particular case, I can tell you what did happen is that the oldest daughter said, I am going to make the decision. We're going to resuscitate this person, and whatever the outcome is, I'm responsible for it. And what happened was that the father, who was not sure if they wanted to be resuscitated or not, came to and said, the rest of my kids said, don't resuscitate me. I never want to talk to them again. They were going to let me die. You're the only one who cares about me. Moved out of the other caregiver's home into this caregiver's house, lived for an additional 6 years, never talked to his family. And so we need to establish one person again as a healthcare proxy, but this also, it's not as simple and straightforward as this. And cultural, religious considerations, objections need to be prioritized. And so the whole point of this is these are some things that we don't talk about beforehand. I have not had any of these conversations with my dad. None of them. And most people won't. But the whole point of this is to suggest that these need to happen. So this is a longer case, and I'll just read it out slowly. The care of an elderly family member is a constant source of stress and tension in the clinical setting. Both the caregiver and the elderly patient have approached the doctor about the negative implications of living arrangements in a multi-generational home. The caregiver would like the doctor to convince the elderly patient to move to a nursing home. The elderly patient does not speak English well and often relies on the caregiver to translate and explain what is being discussed. The point of this was the fact that oftentimes when we see a caregiver present, or somebody who's accompanied someone else to a hospital visit or to rehab, they may not even want to be there. They may not, and again going back to the idea of being willing or able, they may not have the health literacy, they may not have the emotional capacity to deal with all the things that are happening. And so we want to really consider, before we bring that third person in, whether they need to be there or whether they want to be there. The other point is that family members who act as translators, they can often control and manipulate and misinterpret information. And one of the most common things that we saw in this research is that when family members had to explain things, or there was competency issues or language issues, they act as a filter, they act as a gatekeeper, and therefore they are able to withhold certain information from the healthcare professional and also from the patient. And so they play a very, very important role. And so it's oftentimes easier to use a family member as an interpreter or a translator because they're there, but we have to recognize that they're in a real important position there and in a position of power. So the limitations of this research are that they're based on the experiences of one small subset of participants. And for future research, what we want to look at is, well, let's establish some guidelines or some steps for people to take, especially healthcare professionals who are dealing with a caregiver or a family member coming to visits. When should we involve, when should family caregivers be involved, and how involved should caregivers be is some of the things that we'd like to look at in the future. Now, if we look back at the video and just a snapshot of the video we saw earlier, think about some of the things here. What if there's a bad news diagnosis? Maybe the caregiver doesn't want to know. Maybe the patient doesn't want to know. And maybe the doctor's having a hard time even telling everybody about the bad news diagnosis. Why is the caregiver there? Do they need to be there? What is their own agenda for being there? What if there's a language barrier? What information can everyone share? who's going to make the ultimate decision if there's one that has to be made? So these are some of the things that, we can think about and we can talk about. So I wanted to just say that there's no real neutrality of the actors who are involved. Everybody has a reason for being there. They often have their own agenda. The caregivers are in a position to improve, optimize, and coordinate care, but they are also in a position to negatively impact the care of the older person. And that just because a caregiver has agreed to be there at one time and in one place, it may not be the case in the future. And so we need to constantly assess these sorts of things when dealing with caregivers and families, because family dynamics often dictate the relationships that translate into the clinical setting. And that's it. And so I will be happy to talk about some of these conversations and we can have a bit of a discussion. And I'm really sorry for going so fast at first. I just was like, wow, I have a lot of slides to get through, but I'm through. So we can talk and we can talk slowly. Yeah.
Is there a chance we can get a copy of those slides?
Absolutely. So there's two things from this. There's the slides that I can send you, but we've also just written a paper, this friend of mine and I, that's been submitted to Health Communications. And so once that's out, I can send you a copy of the paper as well, or a draft copy if you'd like.
That would be wonderful.
Okay.
Very interesting study.
Thank
just
you.
to clarify, you only interviewed the caregiver,
That's right.
and not the family member themselves.
Not the family member themselves.
And you, in terms of any checks, did you follow up with any doctors to see if there was sort of any congruency, or is that a next study in terms of interviewing?
If there,
like in terms of, is there alignment with what the conversations came from the caregivers and what physicians, the types of conversations physicians have with caregivers? So, or is that a next study?
well, it's not. It's a next study, but the guy who did the fourth review of my transcripts was a doctor, and so we presented him with the data and said, well, what do you see in this data? And so some of the things he said, well, this seems to be a conflict issue. This seems to be a conflict issue. This seems to be a conflict issue. So these are things that we actually overlook, but we should be talking about these things beforehand. And so that's where the 5 conversations came from. Okay? Yep.
What about the role of the caregiver as an advocate and with the doctor or in the medical system? In institutional care, that often is a role.
Absolutely. So
and a positive role.
there are very positive roles, and like as I mentioned, I'm a caregiver, and one of the things I do is as advocacy for my father. There is a very positive role, but that's the one thing that we always focus on is, well, the positive impact of the caregiver being there. And I just wanted to just use this presentation to highlight some of the things that we sort of overlook. That's it. But I'm not downplaying the positive roles in any way. So there is definitely a very positive role in terms of me being there, explaining things, being able to bring those lessons I learned in the clinical setting or in the hospital setting, and being able to ensure that my dad does the things that he's supposed to do. I ensure that the doctor gets the right information. So there is a really important positive role.
But also ensuring that the patient has access to whatever good care they need. Often, like in long-term care, for example,
Okay.
the families feel that they're advocating for their family member,
That's
their
right.
parent, and there's a need. What would you suggest for professionals working with families who are caregivers to be supportive of how to be helpful to the caregiver aside from?
How to be helpful for the caregiver? Well, I mean, one of the things that my doctor, and I'll talk about my own personal experience because I can't talk on behalf of participants here. But one of the things that my doctor has had to do with me is take me aside and say, I know you're getting really upset, and I know that your dad doesn't tell me everything, but you need to recognize that he has his own autonomy and he's allowed to tell me whatever he wants to and whatever he doesn't want to. And oftentimes I tell my doctor things that my dad doesn't want me to tell him. And so what my doctor has said is make sure that the focus is on your dad when we're in the clinical setting, and make sure that you have you maintain a positive relationship with him, because that has to carry over when you go home with him. She's like, I will only see him when I'm in the clinical setting with him. You have to go back home with him, and that's going to be a rough ride home if you guys are arguing over whether he told me everything or not. So that's one thing that I've learned from this. I don't know. I'm not sure.
Is there a rule or a point at which you realize that conflicts are happening and you have to sit down and address that whole conflict? And who is likely to do that?
Well, one of the things that is presented a little bit more in depth in the paper is the fact that in theory you're supposed to have this, and you'll find the literature on all the websites and everywhere else saying we have to respect patient autonomy and we have to make sure that we have this family meeting when we start to see things go downhill. One of the suggestions in this paper is that once the caregiver has to start to accompany the older adult into the clinical setting or go to the hospital with them or whatever, families need to sit down and talk about it and say, okay, if these things come up, how are we going to deal with them? Let's start to address them beforehand, okay? So the point that we suggest that conversation should happen and when families should have their family meeting is once a caregiver has to start to accompany people. Is that helpful, or can
Yes.
Yeah, okay.
Yes.
Did you want to follow up with that, or?
No.
Okay.
I'll just say that within the past 3 weeks,
Mhm.
I have become the caregiver
Okay.
with my husband who's exhibiting a significant cognitive issue.
Okay.
And that is my background, and whether I'm in the office with the, I was in with an occupational therapist, I am an occupational therapist, and all of a sudden I think,
What do you do exactly?
what do you do? And this has happened within the last 3 weeks, so this is very timely,
Okay.
and
Very stressful.
Okay. So if you don't mind me asking, so what will you do? Do you know? Do you have any idea? Or?
well, I will tell you, I want to make it very concise.
Okay.
There was a bank scam
Okay.
where I became very aware my husband was not functioning cognitively.
Okay.
I then negotiated with my connections to get him seen by somebody very quickly. He went into the room with the OT,
Okay.
and I thought, do I get asked or don't I? I don't know. And she said, do come in. And of course she's doing the testing I had spent a career doing
Okay.
with my husband. And he's not doing well.
Okay.
I know to stay out.
Okay.
So we're awaiting the testing. I have some ideas what it might be, but all of this is just at me right at the moment. And we have a daughter, I'm going to say it, who's a midwife, who has an entirely different perspective.
Okay.
And how does she fit in? This is
Well, see, this is the whole point of that
very raw.
relationship, right? So.
So yes, it all makes a whole bunch of sense.
Right.
But how
How do those people all sit down together at a table and participate in collaborative care and make sure that their values align? That's the problem. That's
It
the
is.
trouble.
Well, that's become apparent in the past 2 weeks.
Right. Well, that's become apparent for me in the last 5 years because my sister and I have very different views on how dad's care should be. My mother has her own views. My doctor has her own view. And my dad has his entirely, complete different view. And he used to work in the healthcare system as well. So he's stubborn. He's saying, I know what's going to happen to me and whatever. So it's a cause of tension. And so, one of the reasons I think this is important is that we need to have these conversations before these issues come up and say, well, what are we going to do if, dad can't make these decisions? Or what if we get into a conflict? Like that do not resuscitate situation.
Yes.
They couldn't even anticipate that situation was going to come up. But if you have a plan in place, and the reality of it is that most of us will not have a plan in place. Even after we read things and after, we're told to have a family meeting, we don't plan ahead. A lot of people don't have their power of attorney. They don't have their living well. They don't. And that's just the reality of it. So that causes a lot of tension later on, yeah.
Well, we do.
A lot of families don't want to talk about it.
Exactly. That's the other problem.
Like they look at you like, are you bringing this up?
Why are you bringing this up now? I'm not dying.
Yeah.
There's nothing wrong with me. I'm fine.
I
So
don't want
isn't
to
that the
deal with
better
it now.
time to talk about it? But the thing is that it's also, these conversations also make people feel vulnerable, okay? And so they don't want to have those conversations. Trust me, I don't want to have this conversation with my dad and be like, all right, so we're all going to sit down and we'll talk about all these things that are going to upset us. No one wants to do that. So,
We have had some, but anyway.
Sorry, go ahead.
I was going to ask, you said that you haven't had these conversations
Mhm.
with your dad, and not to make it personal, but like, how do you, if you recognize that these are 5 crucial conversations, how do you imagine integrating them, like having those? What needs to happen in order to facilitate those? Is it something that happens in a clinical context? Is it something that happens in a home context? What supports? How does that happen? How do you get from that
So-
having had those two?
For me, the one thing that's changed on a personal level is that my dad now sometimes wants me in the room. So he'll say to me, okay, you have to come in with me today. And sometimes he says, well, I don't want you there today. And so the next time that happens is, and hopefully my paper's published by then, and I can just put it in front of him and be like, these are some conversations we should have today. But the next time that happens, I'm going to sit down with him and say, well, when do you want me there, and when don't you want me there, and why? And what if in the future we have to make these tough decisions? What's going to happen? And he's going to say, I don't know. And then that'll lead to a further conversation. And the other thing that's unique about my situation is that my dad will ask me to come sometimes, and he'll ask my sister to come other times. Because he says my approach is a bit too aggressive. So I need your sister to come in and be a little bit softer, and I need the doctor to be on my side and all that stuff. So it's some weird dynamics that come into play there, but sure.
My experience,
Okay, just one second.
go
No, that's okay. Go ahead.
as I'm a professional, but also I was a family caregiver.
Okay.
And as a family caregiver, I felt that my late mother, there was a power imbalance. Like with the doctor, she was very hesitant to ask questions, to say things. And I, on the other hand, my training is, to
Ask questions.
talk, and to advocate. So, there's that issue as well. And in terms of the family, you mentioned emotional capacity. Not everybody has the same emotional capacity to deal, with somebody who is ill, with somebody who is dying. Some people distance themselves. And from my experience, where I may have resented, for example, certain attitudes by others, like in the family, I was very involved. But I now understand that, they did what they could. And I think it's important for the family to recognize that. And each person should, like when you're making a plan, each person will do, like in the plan, whatever it is that they're best at doing. Some are better at instrumental tasks, some are better at emotional tasks. So it all depends, like on the capacity of people. Some people don't have time, but maybe they factor finances. Others are better at accompanying people to medical appointments. Others are better at the emotional part, the support. So it's each, I guess, according to their ability also.
So I'll address the 2 points. One is about the power imbalance. So the power imbalance is often there, and there's 2 power imbalances that happen when the caregivers involved. One, because they might be dependent on the caregiver, and then there's a power imbalance between the doctor, who's also a gatekeeper, and from a cultural perspective, there's this like deference to the medical authority. There's also this fear now that, well, what if my doctor, doctors can say, well, I don't want to work with this patient anymore. And my dad's doctor has said to him on a number of occasions that if you don't do what I'm asking you to do, I don't want to be responsible for your death. And so you may have to find another doctor. So that changes things too, because my dad's had the same doctor for 40 years. Doesn't want a new doctor, but he also doesn't want to do what the doctor's saying. So there is the power imbalance that we have to recognize in that relationship. In terms of the breaking things down in roles and emotional capacity and whatever, that all depends on whether people are willing and able and want to do it. Because most people don't want to do it. It's hard. They have busy lives, and the last thing they want to do is to take on this additional emotional burden, or get into a conflict with their parent or their family member, right? So it's hard. And so yes, it'd be easier if we had 5 people who said, well, we've got 5 tasks, so we're all going to break it up, but it doesn't work like that, unfortunately. And 1 or 2 people end up doing everything. So
but some people can do something. So it's really to understand and to recognize that that this person has limitations and this is all they can do. For whatever reasons, either they're busy or emotionally they're not able to do it. Otherwise, there are deeper problems.
That's
so
right.
I think it's important to recognize that the differences
In the individual,
the ability to be involved and how people can be involved as well.
I'll get you in just 1 second. Yeah, go ahead.
Thank you.
Hi.
Forgive me for being a bit late.
No problem.
I'm not sure if you specified or with your study whether you're looking at caregivers and patients or family members who are not in care, in long-term care, or could be in care, or both. Because when one's family member is in long-term care, one basically has to have a POA, a power of attorney, and the person has to be legally, mentally capable of designating a power of attorney. So it is unfortunately really important to do it before someone is exhibiting signs of problems. And there is a blue sheet that I had to fill out twice. I think we evaluated it every year. My late mom was in care, long-term care for almost 5 years. What level of resuscitation or not to choose. And I did change that in her last year or so of life.
Okay.
Appreciating that resuscitation doesn't work very often, and it can be very damaging physically to the particularly elderly person being resuscitated. So I see. So is your work based on people living at home?
Most of these people had their parent living at home with them, and so by the end of the study, there was a couple people who had moved their parents into a long-term care home.
And may I say, with your second video of 3 people in it, I was pleasantly surprised to see the healthcare worker speaking to the patient with intermittent medication, and I expected her to be only looking at the caregiver.
Right.
So that was actually a very good example. I think when someone is showing greater signs of dementia or inability to make their own decisions, the dynamic physically changes so much.
That's a great point. Now, I just want to tell you.
Because I just see, I think this is all excellent work. I just see a lot of differences when one enters long-term care.
For sure.
A lot changes. And is more legalistic and has to be thought about and in effect written down.
My dad will never go to long-term care. He's made that clear to me. So, and there's a lot of people who should go to long-term care but won't. And the last time I went to the last time my dad was hospitalized, the doctor was talking just straight at me. And my dad literally tapped him on the shoulder and said, "Hey, remember me? I'm the patient. I speak English. I know exactly what you're saying. Why are you telling him? Tell me." And so that's an important point that you bring up. And then one of the things that I had said earlier is that the presence of a caregiver sometimes is symbolic of dependence. And so you'll notice that the healthcare professionals are talking to the person who's with them and not the patient. And then the other thing that I noticed and my dad said as well is, you don't need to talk to me slowly. I understand exactly what you're saying. I'm 70 years old, but I still understand everything like I was a 5-year-old. So, anyways, that's...
When my mom was 70, she was actually living still in the States. She probably would have been perfectly fine. But when she was 80, she was unfortunately not mentally perfectly fine to grasp it all. So I certainly hope your father continues on, and it's wonderful that you're able to be, he is able to be with his family as long as absolutely possible.
Well, he wants to kill us some days, but I mean, that's a separate presentation. Yeah.
Can I make just a quick comment? There's a book out, They Left Us Everything, by Plum Johnson.
Okay.
And the first chapter, she describes exactly what you were saying. Chris does the finances, so-and-so does this, somebody else does that. And I just bought it, and it's quite
It's called
excellent.
They Left Us Everything.
They Left Us Everything. She just won an award for it.
Okay.
You can Google her on CBC.
Mhm.
It was in the past week or so, and it's exactly what you were describing.
Okay.
I'm wondering about how this works. If any of the people that you spoke with had more than one doctor,
Yes.
often you have, part of the complexity of navigating the healthcare system as you get older is that you're balancing multiple conditions,
Okay.
multiple chronic conditions, and you're going to see different doctors, and how these conversations work when you don't have necessarily one primary care doctor who manages your care all over,
Mhm.
but you're rather going to this person for this and this and this and this.
Okay, so there's an interesting case that's in here that's not part of the conversations, but I'll tell you about it. There was one participant in here who's a caregiver who said, my dad sees 3 different doctors. We have this primary family doctor, and then we have this other guy. And I said, well, why do you have this other guy and this other guy? And he said, well, there's lots of things that we can't talk to our primary care doctor about. So we got to go to this other guy because I don't want my primary care doctor to find out about this. And the reason why is because they were both Chinese. So the doctor was Chinese and the caregiver was Chinese, the patient is Chinese. And they said, well, the other guy that we see him because he's a white guy. He's a white doctor. And we can talk to him about mental health issues and things like that. And we can talk about depression. We can talk about all those other things. But with our Chinese doctor, even though they were socialized in Canada and they were raised in Canada and they went to school in Canada, can't talk to them about those things because they're from my community. And in our community, it's very stigmatized, mental health issues and depression and things like that. And so I don't want them to judge us because, and I asked them a little more. I said, well, what's the issue with mental health? It's common. These things happen. I said, well, mental health issues sometimes signal a failure on the part of the family. Somehow we've let our older adult become like this, and so therefore we don't talk about those things with that particular doctor, but we have these other ones that we talk to about these situations. So obviously it becomes more complicated, but you can see again that active decisions are being made by caregivers and by patients to sort of negotiate the care that they're receiving from who and from when and for what reasons. Okay, so yes, obviously that relationship gets more complicated when there's more healthcare professionals or there's more caregivers or family members that are involved. Yep. Okay.
My family always discussed these things
Okay.
long before, so I thought we were safe.
Okay.
Because with my grandparents dying in the house, we all knew. When my father had a stroke, we all took that part. So when my mother was in the hospital and at end of life, we thought we knew what she wanted because she'd been very clear, even going to the hospital, I want to die during the surgery.
Okay.
Told the physician this. She was on a ventilator, they took her off.
Okay.
I have no idea how they woke her out.
Okay.
And they said she doesn't want to go, she wants to go back in the ventilator. She doesn't want to be let go.
Okay.
And she couldn't speak at this point, but she could nod. She understood me, and she wanted us to continue giving her therapy.
Right.
And it was like,
But you said something
changed your
else.
mind.
Yeah.
And she couldn't speak, and I thought, okay, what am I going to do? I can't be the person who pulls the plug and she doesn't want it pulled.
Right.
So we put her back on, and I waited till she was seriously comatose and let her go.
So things are changing
You have
minute
to know,
by minute.
even in now that kind
That's
of
right.
end of life, she changed her mind.
Well, the example that I gave you about the guy who said, well, I'm not sure about do not resuscitate, he wasn't sure, really wasn't. But, the 2 family members were sure. One of them said, I don't think he wants to be resuscitated. The other one said, yes, he'll want to be resuscitated. Just as a complete aside, there was the assisted suicide debate is growing in Canada. And there was an individual who had publicized, it was on the cover of Time and on People, and they said, on this time and date, I am going to take this cocktail and I'm going to die. I'm making this choice to die. And I followed this person's blog about 2 weeks prior to, and even up to the day before that they had said that, I'm going to take this cocktail, they were unsure. They were unsure. So things are changing minute by minute, day by day, and so that's why there's this need for constantly assessing what people want, what the patient wants, what the caregiver wants. And it's hard to do, and we don't do it. So it's a great point. Thank you.
Julie asked online, well, she didn't really ask, but she pointed out, it seems that some of these conversations would be occurring already as part of advanced care planning. But then advanced care planning needs to happen more and better.
Right.
So I just said I would mention that.
That's true. So advanced care planning in theory should happen, but it doesn't. And so that's another, maybe that'll be the 6th conversation, is that, you know, when and why we should have advanced care planning and why it's really important. Okay, and have you guys heard of this idea of therapeutic privilege? So therapeutic privilege is a real thing. It was, this doctor friend of mine suggested this to me as well. And so one of the things that will happen with these cases is that I will present them to healthcare professionals as ethics cases. Now there's a real ethics case in the first one, for instance. I'll try to go back to it. About patient autonomy versus harm. Collaborative care, you know, this model where we're holistically treating patients. The doctor says, respect patient autonomy, give them everything. Tell them all the information that they need, regardless of what the outcome's going to be. When you have a caregiver and a patient involved who don't want to know, for instance, the doctor has therapeutic privilege and can withhold information and say, well, that's going to cause more harm to the caregiver and to the patient if I tell them. So this person's going to die anyways in 6 months, so I'm not going to tell them. So there's a debate. Some doctors will say, yeah, I'll exercise therapeutic privilege, and the others will say, I'm going to prioritize patient autonomy, and I have to tell them, and we'll deal with it. Okay? And so the other point is that within certain cultures as well, people don't want to know. That's very, very common as well. Yes?
I recently, I had an issue with a blood condition.
Okay.
Was sent to a hematologist, and then my family doctor, I said, what is it? She said, oh, it's okay. We'll send you when it's, the white blood cell counts are maybe a little higher. I went 7 years later, and the hematologist told me I had a form of leukemia. He said, you mean you didn't know this? And I was furious with my doctor. I felt that I had asked her 2 or 3 times, what's coming, what are you doing? She said, oh, it's okay, we'll just send you along. And I felt that was very patronizing. I wanted to know. It's not a serious condition, and I guess perhaps I haven't gone back to her since. But I felt she withheld information when I asked, and then the hematologist said, well, sat me down and read me the entire report and explained in words of 1 syllable what was happening and made sure I understood. Yet my family doctor had known that, and I had had 7 annual checkups in between.
So I don't know if they withheld the information from you or they just didn't do it properly. That's what I think. That's not therapeutic privilege. It's just incompetence. So that's just a terrible thing that's happened. I'm sorry that that's happened, but that's a mistake that somebody's made along the way. It's inexcusable. So
thank you. That happened 3 weeks ago.
May I ask a question about another family member situation?
sure.
How does the caregiver or family member deal with a case where the caregiver has concerns that seem to be being dismissed by the doctor, the specialist, and it makes it difficult for the caregiver to relate to the family member who therefore says, oh, I'm fine, there's no problem. Where there are concerns with the caregiver that are not being backed up by the doctor because the caregiver may be living with or interacting so much more with the person. So how does one deal with, how does an ordinary person who is a non-medical person deal with a situation with the doctor where the doctor is not backing up the family member who sees concerns?
So the doctor really can't back up the family member. it's the patient, it's the doctor and the patient relationship. Even in that triad, that has to be prioritized. It's the doctor and the patient, and it's almost like the third person is there as a supporting
Well,
actor.
it has to do with mental health issues.
Okay.
Where there's a question of capacity and competency.
Mhm.
Where the caregiver sees one thing, the family member
Says, "I'm
another,
fine."
Says,
Mhm.
I'm fine.
So the doctor should exercise their best medical judgment, and I'm giving you a very generic answer here,
yeah.
and do the test, and you know, for
Well,
capacity.
there are some cases apparently where the tests don't show the reality of what's going on in everyday life.
Okay, and so
Activities of
Right.
daily living, which are starting to be a problem, but they're not showing up medically,
mhm.
quantitatively, but they are showing up qualitatively.
So unfortunately,
Yeah, I know.
the caregiver. No, I don't have an answer for it. I can tell you that the caregiver will, I guess, have to just keep monitoring the situation at home, and keep bringing up their concerns with the healthcare professional and with the patient. I can tell you just my own personal issue with my dad is I've been asking my dad to have a colonoscopy for the last 5 years. My doctor has been saying have a colonoscopy. My dad doesn't want to have a colonoscopy. He says I'm fine. I read everything online about, you know, perfect bowel health and blah blah. I'm good. He had a really bad experience with a colonoscopy about 15 years ago. Absolutely refuses to have one. I cannot force him to have one, and neither can the doctor.
Right.
Even though I tell my doctor all the time, encourage him to have a colonoscopy, encourage him to have a colonoscopy. Can't do it. So, but you know, you can ask the healthcare professional to make a note in their charts at
Well,
least of the fact that this has been brought up. And
Does one see another healthcare professional if one feels that this one is not sympathetic to the caregiver?
okay, but
There's a lot, yeah.
So I want to just raise that point that you brought up to show the dynamics that are in play here, right? The caregiver wants something, the patient wants something, healthcare professional wants something. And so this negotiation is actually moving to getting another healthcare professional involved now, right? So, you know, and it's the caregiver does become the second patient. They have their own agenda because, you know, they want to get help for their family member. So anyways, those are the sorts of points that are brought up in this paper that we wrote. But yeah. Any other comments or questions, or you can always email me after if you have a thought or a question or a concern, or
You provide therapy.
do I? I need therapy myself, to be honest
Well,
with you.
can we make
We
a
can meet
deal?
here every Thursday.
I'm sorry.
Family services has weekly, has a monthly sessions. It used to be on, it used to be on Carlton, no, not Carlton. Anyway, there's an organization that I'm sure people know, that has monthly sessions for caregivers and other folks on different aspects of, yeah.
My problem is I'm still dealing with financial fallout from this.
It's a complicated situation.
Oh.
It's not just medical. It's
Well,
it's lots of other things that are
I'd like to
involved
say
in
this
making-
lecture has been very helpful to assure me that I am in a complicated situation.
You are, yeah.
You're not the only one.
And you're not the only
Oh,
one.
and I'm not
you
the
know.
only one, no. So, thank you.
You're welcome.
Very good.
Thank you.
Is this being presented at the university to the future doctors and so on?
So I used to teach in the faculty of pharmacy, and I used to teach ethics. And so one of the things that I used to do is develop these cases and things like that. So I hope that in the future I will get a chance to take this and present it in terms of the ethics of everything, and to, well, I think just to highlight to healthcare professionals that, hey, when that person shows up at the pharmacy with their older, parent or whatever, it's not just there to pick up a bag. They're there to learn something. They're there to liaise. So they're a resource as well. You know, they're a positive resource that you need to work with, but there's other implications that you also need to consider. So I think that's the plan of that, and hopefully when the paper's published that other people will be able to read it and see some benefit from it. But
One last
Sure,
comment.
please.
I should be keeping quiet.
No.
In the middle of all this, and
Mhm.
there was more we won't go into, it was a pharmacist
Mhm.
who called me, and she said, come in and talk to me, and she was the best resource I had.
okay. Yeah, they're frontline workers. I mean,
She
and-
was fabulous.
Mhm. So we rely on pharmacists and doctors and nurses and social workers to, you know, identify a lot of the issues that come up. So,
I think it's a good point to sort of look at these caregivers, because you always think about the patient and the doctor, and not so much about else is going on there when the caregivers.
when the caregiver's there, yeah.
Yeah.
So, because I can tell you from my own personal perspective, again, I'm talking a lot about myself here. There are times when I go to see the doctor with my dad, and I leave so upset that I can't even talk to my dad for the day because I'm just so upset about everything that's happened, and, you know, you haven't been taking care of yourself, and look at the impact that it's having on me. Why didn't you tell the doctor the truth? You know, so yes, I'm there, and then the next time when I go there, I start talking to the doctor like I'm the second patient, right? So, and it's always sort of therapeutic, but maybe I shouldn't be, right? Sorry, go ahead.
There's a whole literature about caregivers and the need for support, and caregivers are often called the invisible victims.
Right.
And they do need, caregivers need a lot of care and support.
I just want to make one point about that. Sorry, I'm talking a lot too, but this one last point is that caregivers, I think, often don't realize that there's a limit to what they can do. And like, I've had to learn this over the last few years, is that putting in 100 hours a week is actually not making the care that my dad receives better. It's actually making it worse because I'm getting worse, and therefore his health and you know, the care he's receiving is tied to me and to my mom or my sister. And so putting in 100 hours isn't really the best thing. There's a limit, so 30, 35 hours. After that point, the care starts to deteriorate. So yes, we need support, but we also need to help ourselves and take care of ourselves so that we can continue to provide care weeks and months and days afterwards. Okay? All right, so I can provide an email address if you guys want to communicate with me and things like that. Thank you for coming.
Thank
Sharon.
you. Do you have a card?
Yeah, I do have a card.